Greetings and welcome. My name is Sarah Gollist, Associate Professor in the Division of Health Policy and Management at the University of Minnesota School of Public Health. Thanks to all of you who are joining us live today, as well as to those of you who will catch up the recording afterwards. In a moment, I'll be introducing our panel of experts, but before we begin, I'd like to share a few updates and housekeeping notes. Next slide. Our school's experts bring clarity and scientific knowledge to a range of topics critical to understanding and managing the COVID-19 pandemic. We invite you to take a deeper dive into our collection of COVID-19 related science and research stories online. Next, please. Health in All Matters is a weekly podcast produced by our school to bring more understanding of public health challenges across the globe and close to home. We include expert voices from our faculty and their colleagues around the world. Our premier series focuses on COVID-19 and the many issues it brings into question, such as transmission and prevention, life in a pandemic, loneliness and mental health, and the medical supply chain. You can find the podcast on our website or subscribe on Apple Podcasts. On April 26, Twin Cities Public Television premiered Our Invisible Guardians, a 30-minute documentary about public health and the many people who work behind the scenes on issues vital to keeping us healthy. Since the film was made a short 5 months ago, COVID-19 has changed our world dramatically, and public health is now far from invisible. You can catch the documentary online and follow the conversation on social media using the hashtag #InvisibleGuardians. We're holding many upcoming virtual opportunities related to COVID-19. For instance, you can see the two events coming up on May 7th and May 21st. Please visit our COVID-19 website to view all upcoming events. Now to some tips of how to best interact during this hour we have together. For those joining us in real time, questions are welcome and you may submit them at any time. Our audience Q&A will be at the end of our hour together. Please type in your questions by clicking on the Q&A button, not the chat button, on the bottom of your screen. We'll get to as many questions as time allows. And we'll be recording this webinar and encourage you to rewatch it or share it broadly after the event. Today's webinar is one that attempts to address just a few of the many questions that have been brought into the public eye since the novel coronavirus began to change how we work, learn, and live. Luckily, we have the vast expertise of our faculty, community partners, and colleagues to help us make sense of it all. Joining us today are 4 experts with unique experiences and perspectives related to the ethics of the COVID-19 response. So in the order you see on the screen, we have Deborah DeBruin, who's the Interim Director of the Center for Bioethics. She co-led the Minnesota Pandemic Ethics Project and the project to develop ethical guidance for crisis standards of care in Minnesota. Both of those projects were sponsored by and completed in partnership with the Minnesota Department of Health. She is now co-leading the Minnesota COVID Ethics Collaborative, a statewide ethics group convened in cooperation with the Minnesota Department of Health, the Minnesota Hospital Association, and the State Healthcare Coordination Center. The goal is to rapidly share expertise and develop guidance to address the ethical challenges posed by the COVID-19 crisis. Sarah Kessler is an assistant professor of medicine in the Division of Pulmonary, Allergy, Critical Care, and Sleep Medicine. She's the clinical director of allocation of scarce resources for mHealth. She has experiences working with Doctors Without Borders, where scarcity of resources was routine. JP Leiter is senior lecturer in the Division of Health Policy and Management at the School of Public Health. And finally, Joel Wu is clinical ethics adjunct professor for the Center for Bioethics and senior lecturer in the Division of Health Policy and Management. Joel is a clinical ethics consultant for the University of Minnesota Medical Center and member of the ethics committees of UMMC and Abbott Northwestern Hospital. In his capacity as a lecturer, he teaches public health ethics along with a team including myself, and co-teaches a class on public health law. During the COVID-19 crisis, he has worked with Professor DeBruin as well as Dr. Kessler to draft and implement crisis and allocation policies for mHealth Fairview, and also as a contributor to the Minnesota COVID Ethics Collaborative. Welcome to each of you. So moving on to the topic of today. Today we're going to be discussing the ethics of social distancing, rationing, and crisis standards. These are incredibly complex and important issues that cannot be solved with data and science alone. We need to have a thoughtful and proactive application of ethical principles to serve the public during this crisis to enhance our response and ensure that our response is socially just, transparent, and of course saves as many lives as possible. So I'm just thrilled that we have the experts that we've convened today on this panel to talk about these important issues. The way this is going to work is each panelist is going to have about 5 minutes to share their background as well as the perspective they bring to this ethics conversation. After that, we're going to have a moderated discussion among us before we take questions that you all provide through the Q&A windows on your screen. I'd like to invite JP to start the conversation.
Thanks, Sarah. Thank you to everyone joining this afternoon. The conversation we're going to have today is largely going to focus on public health ethics in a pandemic, thinking especially about crisis standards of care and scarce resource allocation. And to kick off that conversation, I'd like to ground us in where we are with the numbers. So as of this morning, worldwide, we have 3.5 million cases confirmed of COVID-19, about a third of that in the US, 250,000 or so deaths worldwide associated with confirmed cases, although we do expect significantly more associated with some of the excess mortality trends that we've been seeing. Next slide. In Minnesota, we've been under stay-at-home orders for almost a little over a month now. And we still have cases growing, but we're at a bit of a plateau in terms of overall need day to day. We have 6,700 positive tests to date out of 82,600 completed tests, about 1,200 hospitalizations. As of today, 373 folks are in the hospital associated with COVID, in the ICU 155, and overall there have been 419 confirmed deaths associated with COVID, 338 of those in long-term care or assisted living facilities. Again, we do expect that number to be a bit higher than it is. Next slide. Over the last 2 decades, public health has emerged as a subfield in its own right from the broader field of biomedical ethics. And as it's done that, part of it is really due to the ethics of pandemic planning. But it's also in part because folks have recognized that to be as useful as possible, public health ethics needs to be able to meet practitioners where they are, deal with the issues of public health policy and practice. So it's really separated out from the questions of professional malfeasance or professional ethics and the broader questions of biomedical or clinical ethics, and focuses squarely on community health, public health, and population health. Some of the foundational principles and values include questions of population level utility, helping as many people as possible, evidence, justice, fairness, and equity, accountability and transparency, thinking about cost benefit, and efficiencies, as well as political feasibility. Next slide. Pandemic planning has a lot at stake. Unlike a mass casualty event that might be a bit quicker, so something like a natural disaster, a hurricane, or an earthquake, they have substantial recovery times, but the actual event itself tends to be a bit more acute. Now, in a pandemic, we have 12, 18, or 24 months, depending on which modelers you believe, where we expect the disaster to be ongoing and then the recovery itself that follows to be pretty substantial. And in this kind of disaster, extended disaster, we have a couple major areas where significant public health ethics implications occur. So things like limitations of liberty. What are we asking people to sacrifice? What burdens are people needing to bear or being required to bear? And is that distributed equitably among the population? We've seen so far in COVID-19, and something we'll talk about today, that the health outcomes aren't being borne equally by racial and ethnic groups. And it might be that the economic toll is not either. There's also the question of allocation of scarce resources like personal protective equipment, ventilators, antivirals, vaccines, and so on. Next slide. So we're going to be talking today largely about the allocation of scarce resources, but I do want to take a minute and talk about the question of liberty limitation. Next slide. We're in the largest isolation and quarantine event in human history. So this began, of course, with China quarantining something like 50 million folks at the beginning of all this. And there were questions at the time, questions that have persisted. Is it appropriate to ask people to bear these burdens, given what's going on in terms of the viral load or spread, what we know or don't know about how deadly it is? And that's continued into the extended quarantine situation we're in now in the US. And the conversation's progressed a little bit, right? So we have these questions of ethics, but also of prudence. Will people follow or try and break these quarantines? Is there quarantine fatigue? We have seen in this past week, folks voicing their opinion that things need to change, and that's being balanced against broader health considerations and economic considerations as well. Next slide. In any kind of situation where a public health practitioner or policymaker needs to make a decision about limiting liberty, there's always the question of, is it proportional to the issue? So is the cure worse than the disease, as has been said? And that can be really challenging. So one of the ways to think about it is with what the Nuffield Council calls their intervention ladder. So starting at the bottom, thinking about doing nothing, to enabling choice or providing incentives, guiding choices through nudges, restricting choice or eventually eliminating choice. So this idea of proportionality, scaling whatever you're going to do to the need, and being as least restrictive as possible, so only going as far as you need to, it's always held in tension. It's held in tension with questions of what will work, of what burdens need to be borne by whom, and again, is that equitable? And largely questions that are beyond health ethics alone, public health or clinical, to what does society need for people to thrive in this condition? Next slide. So we could talk all day about the limitations of liberty, and I hope there are some questions in the chat and Q&A later on. For now, though, I want to focus us in on the topic for today, the allocation of scarce resources, sometimes called rationing. Any time where we have more needs than we have resources, we're in this situation where we have to decide who gets what and when, and who decides. So historically, the federal government, in part due to financing, in part due to the setup of the Strategic National Stockpile, has been one of the primary drivers of decision-making in this arena. And as the administration has made clear this go around, it's going to be a little bit different, right? Where states will be the locus of decision-making for some of the allocation questions. Now, states have always had the constitutional authority to do things like stay-at-home orders, but because of how the finances work and because disasters by their definition exceed local capacity to respond, the federal government's been required. And so now standards are changing and expectations are changing, and that has implications for public health and public health ethics. Next slide. So we're going to continue to funnel this conversation and talk about public health emergencies in the clinical context. And to do that, I'll ask Deb to take over. Deb?
Hello, everybody. I want to thank the School of Public Health for organizing this webinar and for inviting me to participate. And I want to say that it's really an honor to be on a panel with such amazing colleagues. Now, as Professor Leiter has talked about some of the ethical issues that arise in pandemic response in the work of public health, we should note that public health emergencies can also substantially impact the way healthcare is delivered in clinical settings, and I'll focus on the issues in this setting. To do so, let me introduce the concept of crisis standards of care, which is defined as a substantial change in the usual healthcare operations and the level of care that it's possible to deliver, justified by specific circumstances, and then formally declared by government. So some events, like natural disasters such as earthquakes or floods, or terrorist attacks such as the detonation of dirty bombs, have a sudden impact with significant casualties at the outset. Other events, such as pandemics, have an extended impact with casualties building to potentially catastrophic numbers over time. What these diverse events have in common is their potential to overwhelm the public health and healthcare systems, and thus to require rationing of scarce resources, and so the implementation of these standards of care. Next slide, please. Now, under normal circumstances, clinical ethics focuses directly on the needs and wishes of the individual patient. Resources are to be allocated to patients largely based on commitments to promote patient well-being, which we refer to as the principle of beneficence, and to respect patient autonomy. In reality, of course, these norms tend to guide care for more privileged patients. Many individuals lack adequate insurance coverage or resources to pay for care out of pocket or face geographic barriers to access. So, even when resources are plentiful, fundamental principles like beneficence and respect for autonomy may fail to guide care for disadvantaged individuals. In public health crises involving significant shortages of resources, public health and healthcare systems become overwhelmed, and the norms of care, the norms guiding care, must shift to focus on community benefit rather than individual well-being or autonomy. Next slide, please. This shift in focus with crisis standards of care can leave health professionals facing tremendous uncertainty about how to meet overwhelming need while maintaining their fundamental professional values. This may result in tremendous moral distress. The shift in focus can also undermine public trust in professionals, in health systems, and in government agencies. Thus, ethical guidance designed specifically for resource allocation in clinical settings is really crucial. Ethical guidance is referred to as the bedrock for crisis standards of care. Next slide, please. The ethical guidance for public health emergency response in Minnesota has been developed through the two projects that Professor Gullist mentioned in the introductions, the Minnesota Pandemic Ethics Project and the project concerning the ethics of crisis standards of care. Those projects identify fundamental ethical commitments which constitute the most basic ethical obligations for crisis planning and response. These ethical commitments will guide response in the COVID-19 pandemic. As you can see, the commitments require us to pursue Minnesotans' common good in ways that are accountable, transparent, and worthy of trust, promote solidarity and mutual responsibility, and respond to needs fairly, effectively, and efficiently. Next slide, please. The ethical framework for crisis standards of care next specifies ethical objectives to be met in CSC planning and response to honor those fundamental ethical commitments. As you can see, the ethical objectives in the state of Minnesota have been specified this way. Promote Minnesotans' common good by balancing three equally important and overlapping ethical objectives. That's very important that we have these three ethical objectives. First, to protect the population's health by reducing mortality and serious morbidity, but also to respect individuals and groups, and to strive for fairness and protect against systematic unfairness. Each of these objectives is complex. For example, when we think about protecting the population's health, we need to consider not only the immediate threats posed by the crisis, for example, coronavirus infections, but disruption to healthcare, public health, public safety, or other critical services that impact all patients. Throughout the response, we have to think about how these commitments and objectives apply to the complex circumstances in which we find ourselves. So now I'm going to turn it over to Joel Wu to talk to us about how that works.
Thanks, Dr. Bruin. So I want to transition to talking a bit more specifically about the COVID-19 pandemic and how we can take these ethical objectives and these public health values and use them to inform an ethical and just response in a clinical setting. How do we reduce morbidity and mortality during a crisis like COVID while attending to justice and fairness? And I think nationally, there's been a lot of controversy. It's been a struggle to translate these public health ideals and these public health values into a critical care and a clinical context. Generally, when we think about public health interventions and how they're justified, there's a lot of overlapping concepts, but in particular, the things that define public health ethics include a population focus and a prevention focus, as opposed to, in a clinical context, an individual focus and a focus on treatments that cure disease. Often this is described with the upstream and downstream analogy that you'll see in this diagram on the slide. Public health is generally more upstream, where we think about ways of improving community conditions with laws and policies. Then there's a midstream where we think about individual social needs, where downstream we're looking at providing clinical care. And generally, the more upstream we are, the less intrusive the interventions are. And so that sort of refers back to Professor Leiter's original slides, where we're thinking about the correlation between the intrusiveness and the public health value. We want things to be intrusive only to the extent that there's a compelling public health need. I think it's worth illustrating the upstream and downstream idea with the COVID epidemic, and in particular thinking about respiratory conditions, because I think it's actually a really, really helpful sort of condition to illustrate upstream and downstream. So when we're thinking about respiratory conditions in health, upstream interventions and the trade-offs on individual liberties that these interventions may entail would include things like clean air laws and pollution regulations. And then we'll move gradually downstream, where the interventions may become more individually burdensome, but very gradually. So we can start thinking about things like secondhand smoking laws or housing codes that would condemn places that have mold. Past that, then we start thinking about things like providing primary care and preventative care for kids with asthma, where they have like steroid-based inhalers. Finally, once we get all the way downstream, we're thinking about intervention at urgent care clinics or emergency departments. What happens when we get all the way downstream and we end up in an intensive care unit? Next slide, please. So what's happened is that now we're at the end of the stream, so to speak. What happens when we move away from these community level interventions like traffic laws or sanitation to a situation where we have scarce resources in an intensive care setting? And we have to start thinking about what is the best way or the most effective and fair way to reduce morbidity and mortality across the entire community. What's the compelling public health interest that would justify potential allocation or reallocation of something like a life-sustaining treatment in an intensive care unit setting? And in following public health objectives and commitments, we're still thinking about reducing as much as we possibly can morbidity and mortality, but we're specifically thinking about life-sustaining treatment. So how do we translate fairly and effectively that value into a critical care setting when there's not enough to save everybody? And then Dr. Kessler will get into a little bit more of the detail, but our agenda and our goal is to be able to do that in a transparent way that maximizes the most number of lives saved. There are other justifications and considerations for how to do this, including the idea of life years saved, or a quality adjusted life year, or a disability adjusted life year, but they all have ethical and moral implications. Other potential ways of distributing these scarce resources might include first come, first served, or purely random process, but there are also ethical implications for that. Next slide, please. I do think it's worth emphasizing that there are legal implications in a legal environment that this happens in. And Dr. Bruin had previously mentioned that we are potentially thinking about the idea of a crisis standard of care. A crisis standard of care actually is specifically referring to a legal concept. So the medical enterprise and the public health enterprise doesn't exist in a vacuum. There are legal constraints and there are legal permissions or grants of authority. This includes the government's authorization for people to practice medicine or authorize people to be nurses and pharmacists. And it also includes the tools that we have to try and provide remedies that for injuries that follow from negligence, which is medical malpractice. So under crisis conditions where everyday standards of care are not possible, what are the legal obligations and protections for the people that are in the clinical setting? So specifically what a standard of care is it's an element of proving a breach of duty in a tort, and in particular what we're concerned about here is medical malpractice. For there to be a successful medical malpractice claim, there needs to be a duty of care, a breach of that duty of care, which you can demonstrate by not meeting a standard of care, damages or harm to the plaintiff, and then proof of cause from the breach of that duty to the harm. One of the important elements of the crisis standard of care is that it, as in the second definition, enables specific legal regulatory powers and protections for healthcare providers in the necessary tasks of allocating and using scarce medical resources. Under these crisis conditions, it means that there would be protections for the clinical care enterprise to be able to do things that do not meet normal standards of care. Next slide. I think it's also worth emphasizing that although some things do change under crisis standards of care, a lot of things do not change. And so this is in following some of the work that Professor Leiter and Professor De Bruin and I, and also Dr. Kessler have all been working on. And so I do want to also remind people that a lot of things do not change. And so specifically, the obligation of care providers to provide the best possible care does not change. A patient's right to refuse treatment they do not want does not change. That does not go away. The right to supportive care and symptom management remains. And also rights to fair conflict resolution and also a fair distribution of the burdens and benefits, justice, also remain. The things that do change under a crisis standard of care are that the focus gradually shifts away from the individual patient to the community. And then now we start using instruments to try to maximize lives saved by using tools like triage, allocation, and reallocation. And with that, I'll pass it over to Dr. Kessler.
So my job and my colleagues' job on the medical side is to try to put these ethical principles in to practice, and it's been very interesting and educational to work with my colleagues on the ethics side. I've learned so much from them so far. So one thing though that we've really had the benefit of here in Minnesota is that our surge is going to come significantly later than everywhere else, and so we have time to prepare that others have not had time to prepare. And so we're able to look around and learn some lessons. So for example, in Italy, the surge came very, very quickly, and there was really no time there to create or operationalize a plan for any kind of triage or resource allocation prior to the crisis. And the picture here on the right is potential ethical framework that was made by a number of physicians in Italy. And you see here the quote is that it may be necessary to establish an age limit for admission to the ICU. And anecdotally, some hospitals were really only using age or using age as one of the largest priorities simply because they didn't have anything else to do. And so we have the advantage of trying to do something that works better. Next slide. So also seeing what has gone on in New York. So this is a headline from the New York Times from last month. The other option is death, and New York starts sharing ventilators. And so in a place like New York, who also didn't have time to come up with any kind of a system for an ethical framework or putting into practice an ethical framework for rationing ventilators, their way of dealing with it was to do everything possible that they could to not ration ventilators. So You can see here that this is a joint statement from multiple different organizations, doctors' organizations, nurses, respiratory therapists. And they say the above named organizations advise clinicians that sharing mechanical ventilators should not be attempted because it cannot be done safely with current equipment. Other things they were doing is what we do sometimes in patients who have a very severe respiratory failure and are on the ventilator. We do something called prone ventilation, where we turn them on their stomachs, and that can help us a lot with getting better oxygenation and not damaging the lungs as much. Well, they were actually doing that to patients who were awake, and the data is very preliminary and incomplete, but the mortality rates in New York City actually are a lot higher than anywhere else so far. So the efforts to avoid allocation or rationing healthcare certainly didn't seem to translate to better outcomes. Next slide. So what is triage in a medical sense? So trier is the verb to sort in French, and it started during the time of Napoleon. It was a surgeon who worked during the Napoleonic Wars. And it refers to an attempt to sort patients into a category of urgency of need and the likelihood of benefit. So the urgency of need for a resource and the likelihood of benefiting from that resource. And it's a framework for allocating or rationing resources in times of scarcity. Next slide. So, you know, rationing in the United States, actually, healthcare system is actually not new. So one example is polio in the 50s. In 1956, polio vaccinations were first given to children between the ages of 5 and 14, and then pregnant women. And after those patients had received the vaccine, and only after, then it was allowed to give the vaccine to other people. When dialysis was first invented, there were not nearly enough dialysis machines to go around, so dialysis was rationed. And organ, in terms of a transplant for kidneys, liver, lung, heart, organs are still rationed because there are far more patients who need organs than are available. And then, as Dr. DeBruyn pointed out earlier, in our healthcare system in particular, we effectively have a system of rationing because of our insurance coverage, co-pays, or certain things not being rationed, that there are many people who are unable to pay for certain services, and so that's a way of rationing care. Next slide. What is new, if we actually have to do this here in Minnesota, is triaging to ration ICU resources during a pandemic. So there have been numerous attempts here in Minnesota and many other states to provide an ethical framework and guidelines, but we haven't actually had to do it. So the focus on triaging, the fundamental focus is saving the most lives. So we need to figure out who needs the resource and is very likely to benefit from the resource, who doesn't need the resource, so won't need admission to the ICU, won't need a ventilator, and is likely to survive, and then who is very unlikely or will not live even if they receive the resource. So the framework that we use to try to figure this out is we look at the need for the resource, the likelihood of benefit, and then the number of lives that can be saved. Next slide. So in Minnesota, we are trying to put some of these principles into practice, and we're working at a state level with all the hospitals in Minnesota, and the critical care doctors are trying to achieve consensus on an actual scoring system that will put patients in color categories and give them a score to give priority. So if you look at the figure here on the right, this is not our specific protocol, but ours will look something like this when it's complete. So on the top is the green, so green for go is the highest priority. Yellow are patients who have less priority, and that's because they are less likely to benefit and more likely to use significant resources. Red is lower priority and blue is the very lowest priority. So the blue patients, if we were to get to rationing, would be the patients that likely the patients would not receive the resources, or if they did receive the resources, their resource might be reallocated. And then potentially the patients in the red. So when we think about the need, the urgency of need, we use something called a SOFA score, and that is a marker of severity of illness. So it looks at all the different organ systems and gives a score based on how severe the organ dysfunction is. The likelihood of benefit is the prognosis for survival, for short-term survival. And for this, we are looking at severe comorbidities and hospice-eligible comorbidities, and I'll talk about that a little bit in the next slide. And then we're looking at the number of lives saved, which translates, the way we're translating this is how long is somebody likely to need the resources. And mostly what we're talking about in the ICU is the ventilator. So how long is a patient likely to need the ventilator? Next slide. So as we're doing this, we are running into some conflicts between the ethical ideals and the practicality. So we're looking for things that will help predict the likelihood of survival. And in Minnesota, there has been a choice not to ration based on age. Other states are taking into some consideration age as a tiebreaker or a life cycle, but the choice has been made here not to have age anything to do with it. However, the early evidence suggests that there is a very strong link between the age of a patient and whether or not the patient is likely to survive. And so we are closely following the data, and we'll probably incorporate age in some way as an indicator of prognosis. And particularly with COVID, many of the patients come in and they have what's called single organ failure. So really, at least at the outset, they just have, their lungs are really the only organ system that's not functioning well. And so it can be pretty difficult to distinguish between patients who all have essentially the same acute presentation. The other issue that we're dealing with is the issue of comorbidities. So when we think about comorbidities, we think about comorbidities that translate into the potential for a patient to survive a critical illness. So somebody who just has hypertension or just has diabetes, that is not what we're talking about. We're talking about someone who has a comorbidity such that their life is likely to be limited, something like heart failure or being dialysis dependent. And those comorbidities have been demonstrated to correlate with short-term survival in the intensive care unit. However, since we also know that comorbidities tend to be racially biased, and we already know that people of color are more impacted by COVID, we as a group are struggling with how to work on this. And so one thing we at mHealth and other organizations are doing is we're going to have health equity professionals being actively involved in the triage team and in the review process. So we're working out the practicalities of how to operationalize that. Next slide. So another practical issue that we are working out here is that in Minnesota, there's been a choice not to categorically exclude patients from receiving scarce resources. Other states have a very short list of criteria for where you would say that the patient would be excluded from receiving the scarce resource. One example would be a patient who's actively dying or a patient that has no brain function. So here in Minnesota, we have patients in our system who are eligible to receive the resources, who have an exceedingly low probability or perhaps no probability of surviving or participating in life outside a hospital. An example, as I said before, would be terminal conditions or having no brain function. And so we're, again, trying to create a practical scoring system that will address this and try to account for the fact that some of these patients would essentially have no ability to survive. I think that's the end of my slides. So.
Okay. Well, we're going to turn to the point now, and we'll be taking some of the questions that you've chatted in, as well as a few of my own. And I'd like to start by returning to a comment that Dr. DeBruin mentioned in describing the main objectives, ethical objectives, which include striving for fairness and protecting against systematic unfairness. And several of the questions that have come in today have been about a population that often is treated with unfairness, and that's people with disabilities. So I'm wondering if anyone can talk about sources of sort of structural disadvantage that already exist in our society and exist particularly in Minnesota. And so that would be people with disabilities facing discrimination, as well as structural racism and racism that leads to the disproportionate burden of chronic health conditions Dr. Kessler talked about. So I'm wondering if each of you would be willing to talk a little bit, and we can see if everyone needs to talk about how, as the plans going forward that you know of, address each of those priority populations, communities of color on the one hand and people with disabilities on the other. Joel, maybe you could start.
Sure, I'll take a stab at it. I'll start by trying to address the problem of the inequality and also inequity of the distribution of the burdens and benefits of our healthcare system and our public health system on the basis of race. So this is something that's well demonstrated. There's evidence for it, and it's a problem. I think the thing that we really need to think about is how best to address the things that cause this inequality, inequity, and health outcomes on the basis of race. And so I think I want to refer back to the idea of upstream and downstream. Where is it appropriate to intervene on the things that cause this inequality and this inequity? Because it's going to be different if we intervene upstream as opposed to if we intervene downstream. And so I think an analogy might be worth thinking about would be the idea of affirmative action, right? Because we know that there's a lot of evidence that has demonstrated that educational attainment is a direct predictor of health outcomes, right? And so inequality and inequity and who has access to education is something that we can intervene upon more upstream. And we can do that on the basis of race, right? Because there's historical disadvantage on the basis of race. It wasn't that long ago that education was literally segregated. Now, in contrast, if we start moving it downstream, then we have to start thinking about the idea of potentially prioritizing something like a ventilator on the basis of race, which is really different than when we're upstream. And so I think it's important to acknowledge that there are inequities, but the important question is to think about the degree of intrusiveness and the fairness of having a downstream intervention and how we would operationalize it. So even though it's theoretically, I think, something that's ethically and philosophically defensible, how would you operationalize a prioritization for a scarce critical resource on the basis of a historical problem, right? And so I guess my response would be, I really need to think about what we need to be doing upstream, because that's what's causing it. But it's really problematic to try to operationalize in an ICU setting.
Might I continue that, Joel?
Yeah.
So from a public health systems perspective, when we're thinking about a pandemic response, we have an obligation to not make things worse for those who are facing structural and systematic disadvantage. And this is held in tension with the idea of saving the most lives possible. Because if you have groups of people who are coming in that are worse off, or that need resources for longer, you could theoretically save more lives by systematically deprioritizing groups. But that wouldn't be morally appropriate, because obligations of kind of justice and equity demand that we need to serve all groups. And moreover, I would say that obligations of justice mean that for these groups that are systematically disadvantaged, we have to prioritize them in pandemic response exactly because they are disadvantaged. So exactly because they are disadvantaged and more resources will be needed, perhaps in a kind of population-based sense, I think that's a really reasonable way to, in your parlance, Joe, kind of prioritize upstream. It's really challenging when you get to the vent setting, right? Because that's the end of the stream, like you said. So there's a lot that we can do in terms of public health systems prioritization, funding, nutrition support, and access to preventatives as they become available for specific groups, setting up points of dispensing for scarce resources in places and ways that are easier for some groups that don't have good geographic mobility to get to, right? But at the end of the day, when you get to the vents, and that's what's left, you have these questions about how do I prioritize with all of these kind of racial and other inequities coming into the mix. It's an incredibly hard challenge.
So if I could add to that, there are a couple of things that can be done even in the ICU setting to help ensure that rights are protected and inequities are avoided for these groups. One is that you can put in place protections to try to prevent bias from affecting the allocation decisions that are being made. Very practical things like we can make sure that people who are tasked to serve on triage teams have anti-racism training or anti-bias training with respect to disabilities. We can include personnel from equity and inclusion teams on the triage teams, or include ethics personnel on those teams to try to serve as a check against bias. The other thing that it's really important to do is retrospective review of allocation decisions to try to make sure that the way that we're making those decisions does not systematically disadvantage either groups either based on race or based on disability, for example. One last thing I'll say is that there are things that we can do in terms of trying to build the allocation criteria so that they don't themselves introduce bias. So for example, making sure that we're thinking really only about short-term mortality means that persons with disabilities are less likely to be biased against in the allocation decisions, or making sure that we do not allow quality of life or perceived quality of life to be taken into account also protects people with disabilities.
Thank you for that. There's been a couple questions that have come in that are about the end of life and some of these end of life decisions you were just speaking of. So one person asked how providers are dealing with DNI and DNI directives related to COVID patients. And another question that just came in was the commenter was aware of a couple who are in their late 70s who've told their children they don't wish to go on a ventilator for treatment of COVID. And the questioner wonders, should this type of discussion, this sort of openness about end-of-life care and services be getting more public discussion before the Minnesota surge comes? Can anyone speak to those either decisions not to receive ventilators or DNR distinction?
Yeah, I can start a little bit on that. I mean, we're trying and statewide to be more proactive, at least in the healthcare system, about having people talk about their wishes for their care. Yeah, so that's something that we're trying. And then the kind of the DNR DNI issue it's complicated because, again, we know that the data would say that many people who are intubated, particularly older people, they're likely they're not to survive their hospitalization, or they're likely to develop what we call chronic critical illness, which is where they are on a ventilator but are going to be forced to live on a ventilator. So again, important to have these conversations. And then specifically CPR has come up, and we're working on that because COVID is a little bit different from other illnesses in the sense that not only is CPR not beneficial for some patients, but it actually poses harm to the provider. Because when you do CPR on a patient and you're doing chest compressions, or you're doing what's called a bagging, where you're manually putting air in and out of the lungs using a face mask, the virus aerosolizes and it causes increased risk to providers to actually catch it. So some hospitals or healthcare systems have actually proposed not doing CPR on COVID patients at all. We're not proposing that, but we are talking about not doing CPR on patients when we deem it to be non-beneficial. And that's different from what happens now, which is where we essentially have to ask permission or try to convince patients and families not to have CPR.
Okay, thank you for that. I'm wondering if we could pivot a little bit to think about some of the decisions that we will see coming toward us in the future. So 18 months, 24 months, whenever it is, when there's a vaccine on the horizon, some of these questions will come up again, right? When supply is lower than demand, we'll have to see these allocation or rationing questions again. I'm wondering if you could talk about any preparation that's going on or any thoughts to principles or process around thinking about priority populations for receiving a vaccine when it's available.
Sure. Why don't I take the first crack at that?
Great, thank you.
So yeah, of course. One of the nice things, if you can think of it this way, about considering the allocation of scarce resources due to a pandemic, regardless of what kind of respiratory pandemic it is that vaccines have always been one of the first lines of defense or of offense in terms of response. And the question's always been, who is going to get the first batches of vaccines? What's going to guide that? So there have been long-standing frameworks put out by HHS, put out in Minnesota under previous plans that talk about trying to strike a balance between general access for the population in terms of who's really at risk, but also recognizing that this is a primary way to keep people who are key workers or essential workers safe, right? So if there are folks who are taking additional risks to kind of keep society rolling, to treat patients in an ICU or any healthcare setting, but thinking much more broadly, right? The conversation about what a key worker is, we've seen in the media, has really expanded beyond healthcare workers to all sorts of folks who are really fundamentally taking increased risk to keep the wheels of society rolling. So striking that balance between trying to make sure that we cover those risks to the best that we can, and trying to help people who are most at risk from a biological perspective. And I think that kind of framework can be updated and adapted to the particulars of COVID, not necessarily quickly, because we know that the risk and the need is so great that we might expect to see some of the problems we saw 10 years ago with swine flu, where the prioritization groups who needed it was like half the population, right? That doesn't necessarily help when you don't have that much vaccine. But starting small and being able to scale, that fundamental principle, I think we've learned a lot in the last 10 years about how to do that.
Related to that, a question just came in about potential ethics of mandating a vaccine should it become available in a pandemic. Does anyone want to jump in on that question?
Well, I certainly think it should be as the doctor, but I don't think that's possible, right?
As the
It goes back
lawyer,
to the,
I think,
yeah.
I mean, there's constitutional precedent that would say that it's legal. This goes all the way back to the smallpox vaccine in this case called Jacobson v. Massachusetts that we teach in a bunch of our classes, where the Supreme Court recognized that the liberty of individuals is unlimited, and that in some cases, to protect the interests of the community and the general welfare, you can put some burdens on individuals. And so, you know, we're really talking about the range of burdens on individual liberties and how effective they are in benefiting the general welfare. And it really is on the same spectrum as social distancing, right?
Yeah, I mean, I think these questions around ethics are happening. They're not. We can't separate them from the questions of politics. And one of the first questions that actually came in while you were all still speaking concerned the dramatic political polarization we're seeing in the United States today. The questioner wonders, how can we think about addressing these issues within the context of the highly politically charged and politicized environment, particularly, I think, when it goes back to Professor Leiter, when you were talking about the issues around quarantine and liberty infringement. I'm wondering if anyone can talk about what you're seeing around the politics today and how that dovetails or not with the ethical guidance and clinical care you're delivering now. It was an easy one, so just feel free to jump in.
So I'd be happy to jump in. What's really interesting in the analyses of who is objecting to the current limitations, it seems to be not just a general polarization, like a Democratic-Republican thing, but the edges of the ideological spectrum with a little bit more of the kind of economic vulnerability thrown into the mix, right? So if there are particular groups that are getting hit harder, that doesn't necessarily match ideology. But there have been these really interesting investigations, I would say, into how our national political opponents are leveraging that polarization to push us apart more. And so, I mean, I don't mean to sound too Pollyannish, but it sure would be nice if people didn't see masks as a political statement, but rather one of being able to debate, does it work from a scientific perspective, or does the fact that it protects you but might not protect me mean that we all have an obligation to each other to do it, right? I think that there have been cases this morning where the mayor of a small city, Stillwater, Oklahoma, had to rescind an order because there wasn't enough police to enforce it, and there was pushback on the private business community trying to enforce a mask order, right? I think those kinds of cases are going to pop up all the time, and it really shines a light on where the personal meets political, that meets the ethical.
Thank you. We have to close out, so I want to ask a slightly more optimistic question to round us out today, and that comes from a couple questions that have come in, which surrounds what do you see in the horizon from this experience, whether that's in terms of a more resilient public health infrastructure, perhaps, or potentially even movement on the healthcare for all or universal healthcare dialogue. Are those issues that you see emerging from this crisis, if you are comfortable guessing what might be in your crystal ball in the future?
I'll take a stab at that. I don't have a crystal ball, but I do think that we are being forced to confront some issues in the response to this crisis that may really change the way that we proceed or operate in the future. And some of those issues are the ones that we've talked about, things like healthcare access, health disparities, disability rights, those kinds of things. Those conversations have really moved to the fore. They belong there. And we should continue, and I hope that we do continue to have conversations about them. The other thing that I will say is that it's often the case in discussions about public health emergency planning and response, when we think about the ethics of rationing, that we acknowledge that in that context, we have very explicit, transparent conversations about the allocation of healthcare resources that provide kind of a model for the way that we should think about the allocation of healthcare resources in times of non-crisis, in normal times. And so I would hope that we could follow that model even once the crisis is ended.
Thank you so much. So thinking about this crisis, of course, illuminates so much inequity and so many difficult questions, but those are the types of questions that we need to be talking about all the time, keeping transparent, figuring out a way to deliberate about them across society with experts and the public alike. And so that's something that public health ethics paradigm that we hope we'll take with us into the future. So I just want to thank each of the panelists today. This was a really wonderful conversation, and I also want to thank all of you for joining us today for this. So thank you. Hope to see you again at another webinar.
Thank you.
Thank you.